Okay, so you should be back to a normal screen now. Right? You're on mute. I'm just looking for your presentation that you sent me, and I'm going to email it to myself.
Let me send. Are you able to type something? There was something I missed, but it was just a very short thing on slide. On slide 5.
Okay, hang on one second though. I have to figure out how to redo this. Let's see.
Or can I just send you an email right
Yeah,
now?
yeah, just email me the slides. Do you have my email address?
Just a minute. Let me check. Compose. This is Qualcare.
Yes, do that.
Spelling QUALCARE.
QUAL-CARE. At outlook.com. Okay, Chad, we can go ahead and start. I think you're on mute.
Hey guys, can you hear me?
Yeah, there you go.
Can you? Okay, cool.
Yeah.
I got
We're just
for the technical delays. Yeah, sorry about that. But yeah, we're gonna. So you guys are gonna we're just gonna focus on the intro today for MSK, and then I'll just continually add in a little bit of practical, business related. I guess you could call it channels that we need to focus on. This is something that the doctors in the group actually requested specifically, which is great. And it's a welcome addition to the curriculum. And we'll obviously continue this for the next cohort too. So yeah, thank you, Joe, for making the arrangements. And yeah, I really appreciate it.
No worries. And Chad, if you can just give a brief, and I always like when you do this, to give a brief overview, especially to my sonographers who may not be used to the program, of what the program is about and exactly what you're attempting to do, your goals with the program.
No, that's fine. Yeah, so the initiative or the model that we're sort of creating is an empowered clinician. So by that I mean a clinician who's independent, entrepreneurial, is able to identify commercial opportunities wherever they find themselves, and focus along with telemed are the two main tools we've decided to use to equip the doctors to create this this model. And they'll be using focus, specifically MSK now in this session, as a mechanism to deliver care to patients via other existing practices. So we're going to be bringing services to existing trust networks, and the doctors will be positioned as selling their offering to the GP, hospital, clinic market. So yeah, quite exciting.
Excellent. Excellent. Okay, perfect. All right, guys. Well, I'm not going to do much talking. Nelly, I wouldn't worry about that slide, just ad lib it. But I'm not going to do much talking. I'm going to have one of my sonologists that is a trainer. And you know what? She has such a long list of accolades. If I did this, we would be here pretty much all night. She's also actually now in studies for her master's, in addition to her other degrees. She's now in Uganda studying for her master's in in ultrasound, basically, with one of the ultrasound programs there that's soon to become a PhD, the first PhD ultrasound program in Africa. Actually, it should be in the world because I can't find another one anywhere in the world. Nelly, maybe you can correct me. But what I'm going to do is basically have Nelly introduce herself before she gets into her lecture material. I do want to say about MSKs, and this is kind of a disclaimer I always do when I'm doing MSK, anything teaching. MSK is a very specialized field. It is not as simple as it sounds. People say that MSK are taking MRI place. The advantage to MSK is that you can scan at the same time that you can do movement. So you can see a lot of movement when you're doing it. However, it is a difficult thing to learn. In the United States, I'll give you an example. When you're doing your obstetrical rotation and ultrasound for accreditation and for certification, you need, I think it is 20 cases. In MSK, you need 100 cases. So it gives you an idea of how different the fields are when it comes to MSK. So we don't expect any doctor to become professional at MSK after the first lecture, but it's something, for instance, I had my Achilles ruptured, and the sonologist that did me used ultrasound to actually find the rupture so they could do a closed reduction on this rupture. But that sonographer had been doing this for like 20 years. So it just gives you an idea. So Nellie's going to go over the basics, just an introduction to MSK and how it's used in the most popular sense, which is sports medicine. And Chad, I always like to give, you're an entrepreneur and you're training a bunch of entrepreneurs. One of the big opportunities I see in MSK for the doctors on here is when you go to sports games. Like my daughter was in the rugby finals for South Africa. She actually represented South Africa in England, and they had the tent set up for injuries, but no ultrasound was there. And I think even if you're talking about professional, high school, primary school sports, there should be an ultrasound in the sports tent to be actually, diagnosing these kinds of things. So with further ado, I'm going to turn it over to Nelly. Nelly, please go ahead and give a full introduction to yourself. Don't be shy. And then you can launch right into your sonography and your lecture. Thank you. Over to you, Nelly.
So good evening, everyone. And my name is Nelly Rono, and I'm a consultant sonographer. I've actually been doing ultrasounds for the last 10 years, and I developed a very keen interest on MSK, musculoskeletal ultrasound. And that is an area of interest that is I'm very passionate about. And as you've heard from Joseph, not so many sonographers actually go into MSK, especially in our setup, since we don't have subspecialization in Africa. In Kenya, actually, we also do, I'm from Kenya, and we do mostly, for sonographers, we are a jack of all trades. You do everything. You do obstetric, you do MSK, small parts, and all that. But of interest to me is MSK. And I've also been teaching at the Kenya Medical Training College for the last 5 years. And I teach sonographers both in their, and I'm also a clinical instructor. So I teach both in class and in their clinical areas. And beyond that, of course, as Joseph has said, my background is radiography. In Kenya, for you to be a sonographer, you must be a radiographer. Unlike probably in the other Western countries where you can just do ultrasound directly as a specialty. But in Kenya, you first have to be a radiographer. So I did my degree. First, I started with an associate diploma in radiography. Then I did a higher diploma in ultrasound, which was 10 years ago. After that, I did my bachelor's in radiography. And now this is when I'm doing my master's in ultrasound. But I've been practicing ultrasound for the past 10 years. So ultrasound is an area that I'm very passionate about. And I think that is basically it. I have participated in the POCAS trainings with QualCare, and we've done so many other trainings with Joseph. And I've also I also participated in one of the the biggest POCAS training that was funded by Bill Gates in 2022. It is the biggest ever in Africa. And we deployed so many portable equipments for POCAS in obstetric. I've also developed different curriculums for AMREF Kenya. And the training course was meant for clinicians and nurses, those people who are at the point of care, emergency unit and all that. So we're developing their e-learning protocol and also the curriculum for them and how it is going to be implemented. Then beyond that, I've also done curriculum for Karatina University. They're also beginning their radiography course. And KMTC, that is the Kenya Medical Training College, which is our benchmark. We've also done so many curriculum reviews. So with that, for me, I would say that I cut across both the practice and in teaching and also in curriculum development. So I'm excited to be here this evening, and I would be happy to, welcome any questions as we go along. And today we are going to focus specifically on MSK POCAS. And of course, we all know that POCAS is point of care ultrasound. So without much ado, we can proceed. So Joseph, the next slide. So we have an overview, and this overview is just to, demystify what we are going to be covering, especially for today's presentation or the lecture that you're going to have today. And we are going to cover the target regions, which we cover in a full MSK POCAS training. And then we have the clinical relevance in sports. We also have the introductory scanning demo, which will be done much later. For today, we are only doing the lecture, which is a theory lecture. And of course, we are going to, for those who will be, interested in doing MSK POCAS, we'll be able to tell you what would be the next course of action. Next. So what is POCAS? What is MSK POCAS? You already know what POCAS is, and POCAS covers so many areas. It is point of care ultrasound. It means it is not comprehensive, but it helps you to be able to make judgments very quickly, to be able to make, intervention if need be without wasting time, and being able to manage our patients well. So for the MSK specifically is what we are going to focus on today, but we all know that there is POCAS, which is obstetric. There is also the different types of POCAS that Joseph will be able to tell us at the end of this presentation. We also have emergency, which is used in the emergency unit, trauma units. And for today, specifically, MSK POCAS for musculoskeletal is evaluation that refers to the real-time ultrasound imaging performed at the bedside, which could be, if a patient is not able to come to the department or you want to make decisions right there and there. Then there is also, you can use it at the clinic. You can also use it in the field. Remember, for MSK, mostly it will involve, people who are active in sports. And we want to use it right there in the field to be able to assess the muscles, the tendons, their ligaments, joints, and even soft tissues. And we will see as we move along what we will be able to scan while we are in the field. So next slide. So MSK, why do we do it? One, we've said that it is for rapid diagnosis of injuries, especially when we have our athletes or people who are active in the field. Remember, MSK POCAS is mainly for sports medicine in most of the cases. And two, it is non-invasive, it is dynamic, and it is portable. Dynamic means we are able to assess, for example, when we are doing an MRI, those are static images. But if I want to check something like an impingement, you have to do the dynamic maneuvers. You actually do, like, for example, if it is the supraspinatus, for example, you want to check if there is impingement, you make sure that while you move your hand, you're able to see the specific tendon, and that is what is referred as dynamic. So for ultrasound and in POCA specifically, you'll be able to check and rule out, no, this one is not impingement, this is a tear, this is a partial tear or a full tear. Then it enhances clinical decision, that is making a clinical decision making in sports and in rehabilitation. And in terms of rehabilitation, of course, we want to see the improvement. Yeah, move to the next slide. We want to see, like, for example, it is not practical for someone to have an MRI every probably 3 months when they go for review at the doctor's clinic, but they can be able to get an ultrasound, and it is able to tell us the healing process. Is it healing? Is it worsening? And all that. And that is why we use it. So why MSK POCAS matters in sports medicine? One, we've said that we want to detect tendinopathy. And as we all know, tendinopathy is just a general term that refers to any kind of, any kind of, what would I say? Any kind of pathology in the tendon. It is just a general term. But then we have the specific terminologies that we use to be able to tell what exactly is this. We're also able to check tears. We can check ligament injuries. We check for effusions, like if we have effusion in the knee and all that, we can be able to check. We can also, it guides in rehabilitation process, and we said it is, the main decision here is to make sure that there is return to play decision. If this, we are able to assess that this player or this athlete is able to go back, or are they even ready or not yet? How much time should we give? And even post-operative, we want to check the healing process as well. Then we want to reduce reliance on MRI for common conditions. Remember, of course, MRI, like in our setup in Kenya, MRI is very expensive. It is not covered by it is covered by the NHIF, which is SHA, that is the provider, the government, but it only allows one MRI in a year. The rest you will have to be paying on your own. So then ultrasound is able to help us to be able to reduce over-reliance on MRI. And actually, studies have shown that ultrasound is as sensitive as MRI in most of these conditions, but it also depends on the technical expertise that you have. Otherwise, it is still as reliable. Then it enhances dynamic assessment, as we said. During movement, you can be able to check some of those, if actually the tendon is sliding as it should be, or it is impinged. It is also used by orthopedic doctors for ultrasound-guided procedures. For example, it can also be used for those guided ultrasound guided procedures. There is that injection, the dry needling and all that. Then there is effusions. If you want to drain an effusion, you cannot just do it blindly and assume that you are able to get to, otherwise you may be causing even more harm. So you're able to use an ultrasound equipment to be able to do the ultrasound guided procedures like draining of those effusions. So the next slide. So what are the target areas in our complete MSK POCAS training? Remember, MSK, we have the upper limb and we have the lower limb. And for the upper limb, we have the shoulder. And in most cases, in the shoulder, we check the rotator cuff and the biceps tendon as well. And we also check the bursars. Remember, we need to check those bursars because that is where we could have bursitis, we could have collections and all that. So that is what we will be able to check on the upper limb, specifically on the shoulder. We'll focus on the rotator cuff. And of course, we know what involves the rotator cuff. The first one, we have the subscapularis, we have the supraspinatus, we have the infraspinatus, we have the teres minor, and we have the long head of the biceps tendon. Those are the things that we check on the shoulder. Then, of course, on the elbow, we want to check the common flexor and the extensor tendons, which sometimes is known as the the tennis syndrome, I think, and the golfer's syndrome. So it usually involves the elbows. So that one, both of them would be the common flexor and the extensor tendons that we will be checking. Then we have the wrist, and in the wrist, of course, we'll be checking the extensor tendons, and we also have the flexor tendons, and we actually follow them all along because most of those tendons, they terminate where they insert are the fingers, and patients will come with varied complaints, and we are able to do a quick assessment and see exactly what is happening around the wrist and the hand. You cannot separate the wrist and the hand when you're scanning. Then we have the lower limb, of course, and that is the hip and the groin region. We'll be checking the iliopsoas and the adductors. In the knee, we want to check the quadriceps. We want to check the meniscus, if there is any, meniscal tears. We also want to check if there is a fusion. We want to assess and check what is happening in the knee. Then we also have the patella tendons in the knee, which most of the athletes actually get rupture. And that is especially for track and field. I usually see most of them, they tear their patella tendon, which is also known as the patella ligament. It is one and the same thing. And we have the Achilles as well, which we are going to learn about today. Then we have the ankle and foot, and just like the wrist and the hand, the ankle and the foot, you don't separate them because where it originates, it will insert at the foot. So you have to follow, even like the plantar fascia, you'll be able to see how it looks like. And therefore, you cannot be scanning one point and you're not able to move forward because most of the time, these patients will come presenting with pain and they'll tell you, I have pain behind my foot somewhere there. So you need to actually see that where exactly could this be coming from. Next slide. You skipped one.
Oh, sorry.
So today, for the introductory focus that we want to focus on today is the Achilles tendon and the plantar fascia. Those are the ones that I want to focus on today. But in our full MSK focus training, as I've said, we have the upper limb, the lower limb, and even later on, as you will see, we also, musculoskeletal does not end at the joints only. There is also abdominal, the anterior abdominal wall is part of MSK. Only that in sports, mostly we measure on the tendons and the muscles. So for the introduction today, we are going to do the Achilles tendon and the plantar fascia. And commonly, it is injured in runners, athletes, and any active individual. Most of them, they rupture the Achilles tendon, and they could also present with plantar fascia pain. Then we have the high prevalence of this is actually in sports-related injuries. And the learning goal today is to demonstrate the basics of scanning these two structures so you understand the value of MSK focus in clinical practice. So let's start with the anatomy review of the Achilles tendon. And as we all know, the Achilles is a thick tendon located in the back of the leg. And you will be able to see that on the next image there. It connects the gastrocnemius and the soleus muscle in the calf to an insertion point at the calcaneus. And the calcaneus, we all know, is the heel bone behind the foot. And it is the strongest tendon in the body. And it allows people to push off while walking, running, and jumping. Most of us, of course, we cannot avoid walking, running, and all that. So you can imagine this is the tendon that is able to allow you to do all that. So the Achilles tendon is the strongest tendon in the body. So let's move forward. And as you can see from that image there, from the anatomy, the Achilles tendon, you can see there is, we have the Achilles here. As you can see that, we have the soleus muscle. This is this small muscle here. And the gastrocnemius is what is usually on the calf region. So the Achilles tendon actually is what connects the gastrocnemius muscle, the soleus muscle, to the calcaneus. And this is just a, the gross anatomy of how it looks like. But on ultrasound, this is how it looks like. The Achilles tendon, you can see the soleus muscle here when you scan. This is the Keger's fat pad. This is actually the fat pad. And we find fat pads where there is a joint, when something else is joining to another. In this case, it is the calcaneus, and we are able to find this fat pad here. And the fat pad usually acts as a cushion to absorb shock and all that. Before this Achilles tendon ruptures, then the fat pad will have done its work. And as you can see there, it attaches to the soleus and it inserts here at the calcaneus. So the whole of this here, as you can see there, is the Achilles tendon. Next slide. So the Achilles injuries can occur in several places, but the most common area is at the muscle tendon junction, which is usually known as the myotendinous junction, where the muscle ends and the tendon begins. That is where the most common area for Achilles injuries. And this is an area where the calf muscle joins the tendon. That is what we've said. And this junction has a smaller blood supply. That is why it is usually very difficult to heal, because when there is no blood supply, then it means healing also is very slow. And the blood, this junction has a smaller blood supply than does the muscular area of the leg. However, this makes the healing process slower than it is in many other leg injuries because of that blood supply. Next. So scanning the Achilles tendon, the technique, how do we do it? The patient, you position the patient in prone position. You can have the patient lying on the couch on a prone position and the feet hanging off the table. The transducer that we use is a linear high frequency probe. So for most of these tendons, we want a high frequency transducer. And why do we use a high frequency transducer? Because it has lesser penetration. Remember, most of these tendons are more superficial, and that is why we use a high frequency transducer. And basically, if you can use between like a 12 to 15, it is still adequate. 10 to 18, still okay. And you can also adjust your frequencies even on the equipment if you need to adjust. So the views, what do we usually do? Of course, in ultrasound, we know that any ultrasound, we don't just do one plane. We have to do both planes, and that is the longitudinal, which is also known as the sagittal plane. And we also need to do the transverse, which is the axial plane. And in longitudinal, what do we want to see? As you saw in that first image, and we'll see in the subsequent images, you have to have that fibrillar pattern. That fibrillar pattern is those lines that are running parallel. What are we checking? We want to see that there is no discontinuity. We also want to check the thickness, and we have different tendons have their cutoffs because they are in different places. For example, for the supraspinators in the shoulder, it would be a 6 to 8 millimeters. When we go to the long head of the biceps tendon, it would be 2 to 6. And we will learn why we need to know these measurements, or what are those cutoffs for. Then we have like the quad, which is very big. It usually varies between 6 to 11. We could also have things like the common extensor, the common flexor. Those are 4 to 6. So each part has to have its own. You need to know the thickness. And for this Achilles tendon, usually it should be 6 millimeters. That should be the cutoff for the Achilles tendon. So next slide. And usually for the Achilles, we measure it 2 centimeters proximal to the calcaneus insertion. That is the thickest point. Remember, when you see the Achilles tendon, all the parts it is not the same in size. So you have to measure the thickest part, and usually that is 2 centimeters proximal to the calcaneus. So in prone position, now we are moving forward with the the patient positioning, the technique, what we are doing. In prone position, let the foot hang outside the edge of the examination table, and at rest. It should not be, straining, or with the toes lying over, stretching. And then look clinically to the position of the foot. You have to compare the two so that you're able to check. You can actually diagnose like an Achilles tendon full thickness tear by comparing both legs. And even in MSK or even any other thing that usually are two, it is always advisable to compare the two. You check, if you're not very certain about what is happening in this other one, you check the other one if it is the same. So when you have this patient lying prone, just check both the right and the left. If you're scanning the right, compare it also with the left so that you check if it is the same. Next slide. Oh, sorry, the previous one. So you examine the Achilles tendon from its myotendinous junction. That is what we said. And even for sonographers, when we are doing the scanning, we don't always just show the tendon alone. You have to show from where it is progressing from the muscle, and that is the myotendinous junction. That is what we talked about. And you should also show all the way to its calcaneal insertion by means of transverse and longitudinal planes, as we've talked about. Next. So while you're imaging the Achilles tendon on short axis, you tilt the probe on each side as you go down, as you scan on a transverse. Remember, the short axis is when you put your probe on transverse. As you scan through all the way, you should be able to rock your probe side to side. As you go down, you check. This is also to assess the peritendinous envelope. You want to check the tendon sheath so that you're able to see how it all looks all the way. Then you measure the size, and we've talked about the sizes, and we said for the Achilles, it should be less than or equal to 6 millimeters. If it is above 6 millimeters, then it means it is thickened. So the Achilles tendon has to be followed down to its calcaneal insertion, and you also check the retro-Achilles and retrocalcaneal bursa. And that is why even when you're doing the Achilles tendon, in most cases, you also need to check the plantar fascia. And that is why I brought these two together, because sometimes it is referred pain. Sometimes the fluid has collected down, because remember, it is following gravity. So most fluid will actually go down. So that is why it is important to be able to check the retro-Achilles and the retrocalcaneal bursas. And you can also include the plantar fascia. Next slide.
Nelly, I have a question. There's a question in the chat. Are there variations on the measurements that you've just said?
The variation is, what I would say is that I said every tendon has its own cutoff. Remember, all the tendons are not equal. Like, for example, this Achilles tendon, as you can see, right here is thicker than even the other part. And we said we measure on the thickest site of that tendon. That is where we measure. So the variation is the range that I have been giving. For example, I said like the patella tendon is between 4 to 6. So it is within that range. If it is above, then it is thickened, and that would be pathological.
Understood.
Yeah. So moving forward, that is how we scan the Achilles tendon. This is what we've been explaining with the theory, but now this is the real positioning. This is how you position your patient. The patient is lying prone. You make sure that the leg is lying over the couch. And this is, of course, the sagittal view. There you can see, and this is the transverse view. This is how the pointer will be facing. And in most cases, and as sonographers or even those who will be doing the POCAS, you need to know that the pointer, the marker on the probe, should always be facing to the patient, towards the patient's head, or to the right of the patient. And to the right of the patient, depending on if you're right-handed like me, then it will be facing me. But if you're left-handed, then you ensure that the probe is facing on the right side of the patient. So in this case, when you flip that pointer, and usually how do we test? On the screen on an ultrasound machine, for example, if this screen here is the ultrasound machine, the right would be on this edge. So what do you do? How do you test if you're not sure or if your probe doesn't have a marker? What you do, you tap on the edge of that probe and you will see the movement on the corner. So that is where you ensure that your probe marker is in the correct place. Otherwise, it flips the anatomy. If you put your marker now opposite, maybe facing, caudally to the feet, then it flips this whole anatomy. It would look like if you're scanning the right leg, the right Achilles tendon, it will give you anatomy of the left because you have flipped your anatomy. So you also make sure that you check where the pointer is facing. So for this is where we position our probe. The marker would be facing cranially to the patient, towards the patient's head when you're doing the longitudinal, and transverse, it will be pointing towards myself because I'm right-handed. So if I'm standing here and I'm scanning here, then the pointer or the marker will be facing me. So what do you expect to see? In this image here, as you can see, you have to check you can see the soleus here, that is the muscle, and we said that is the origin, where it originates, and it goes all the way to the calcaneus where it inserts. And you can see these white arrows here is what is demarcating the tendon itself. We talked about the fibrillar pattern. Fibrillar pattern is, these parallel lines that are running in that tendon. That is how they look like. That is a healthy tendon. We have the fat pad there, which is known as the Kegas fat pad. We'll have the calcaneus.
Sorry.
It's okay. We have the calcaneus, and we know that for the bones, they usually cast a shadow. Yeah, here. So you can see here, we have the calcaneus here. And what are we checking? Even when we are checking the tendons, we not only check the tendon alone, we also want to check the continuity of the bone itself. Yeah, because there could be other pathologies like in arthritis. The continuity, that regular continuity of the bone. And during scanning, when you'll be doing your technique, the actual practice, if you don't press, somehow we tend to press a little bit so that you're able to get this very clear, nice image. You don't just put the probe, you slightly press and you're able to see this contour. There is no irregularity of that bone there. So as you can see, this is the longitudinal, yeah? And that is this view. This is what you expect to see. On this view here, this is the transverse. Remember, you're cutting across. It's like you're slicing across the tendon. If the tendon is like this pen of mine, the longitudinal would be along this pen. But the sagittal means you're cutting cross-sectional. You're moving along. And this is the tendon. This is how it would look like. And one thing to note about when you're doing MSK, there is an artifact. And artifact is, it can be beneficial, it can be destructive. For example, we have an artifact in ultrasound, and especially in musculoskeletal, it is very common, which is known as anisotropy. And anisotropy, like here, you can see this can easily mislead me that this is bursitis. Yeah, it can mislead me that this is, fluid somewhere there collecting. Yet this is an artifact. So how do you do away with these artifacts? Because it can actually mislead you and tell you this is pathology, yet it is an artifact. So what you do is when the difference between if it is pathological and when it is an artifact is that, you change the angulation of your probe. When you just rock your probe a little bit, it disappears. It comes back and all that. That is an artifact. If it is persistent, then possibly that is a pathology. So you need to be aware of anisotropy. It is very common in MSK. And you can actually find, you can easily say the patient has, tendinosis because of anisotropy, yet it is a pathology, it is an artifact. So you need to get to know those techniques. And the only way you can be able to do that is to do it practically. You actually see that anisotropy. When you change the angulation or the position of your probe, then it disappears. Then you know that this was an artifact. Then, so you check the plantaris tendon, which is, in case of complete Achilles tendon tear, the plantaris may actually mimic residual intact fibers of the Achilles. It is very thin. And I'm sure when you'll be doing your practice, you'll be able to see that. Then dynamic imaging during passive dorsal and plantar flexion help to distinguish between partial from complete Achilles tendon tears. Those are now the dynamic maneuvers that we were talking about. When you dorsiflex, you can be able to differentiate between partial tears and complete rupture of the Achilles tendon. So next
And
image.
can I add to that?
Yeah.
Having gone through a partial rupture of my Achilles, that's the way that the orthopedic doctor was actually skilled in doing MSK ultrasound. I don't know how he learned it, but he did. And when I complained after a run, I complained that my foot did not really feel the same. It wasn't painful, but it just felt weird. It felt like I couldn't move my foot normally. So he put me in this position when I went to him, and luckily he was in my practice. And he scanned me and he showed me on the screen actually where the partial tear to this was that he had to go and repair. And because he was able to do this kind of scan, he said normally he would have sent me to MRI. That would have taken a while. I've got to wait to get in queue for the MRI technologist because they have other things to do. But ultrasound, he was able to just use one of the ultrasound rooms, use a laptop ultrasound and scan it and say, okay, nothing to eat after midnight, be in my surgery tomorrow and I'll repair this for you. Because now I know exactly where the tear was. So he made a little mark on my leg and he actually did a closed repair of the Achilles tendon simply because he could actually know where the tear was. And actually, Nelly is 100% right when it comes to the Achilles tendon, and actually a lot of the tendons work this way too. Healing is very slow, and he actually scanned it as he injected cortisone into some of the sites that he closed because we had some swelling in those sites. So he did an ultrasound guided POCUS injection, and I think that's what Chad was talking about also on the chat, was POCUS is very good at injecting MSK also. So back to you, Nelly.
Thank you. Thank you, Joseph, for that addition. And let's move forward. So what are some of the Achilles tendon condition and the issues that we are likely to encounter now that, it is a very quick thing. You see, you just put your probe, check, make sure there is no anisotropy. It is actually, and we will be able to see the sonographic appearances of some of those conditions. So chronic long-lasting Achilles tendon disorders, they range from overuse injuries. You might find that, Joseph, it had been a progressive thing over time. And eventually now it is overused. Yeah. And that causes inflammation or degeneration to acute trauma such as Achilles tendon ruptures. Then pain along the back of the ankle or the heel are often the result of distinct problems along the course of the Achilles tendon. I'm not a clinician, but I know that when you're doing your assessment for the clinicians, they usually do a lot of, clinical history, the patient assessment, like being able to touch and tell where is it feeling pain and all that. And that already can be able to give you, if a patient is complaining about pain specifically at the back of the ankle or the heel, you can actually start thinking about the Achilles tendon and the plantar fascia. Then so that would show us the distinct problems along the course of the Achilles tendon or at its point of attachment to the heel of the foot. Remember, we said that it originates from the high up to on the soleus muscle all the way to it attaches to it inserts to the calcaneus. And remember, for the in MSK, the attachment, the attachment and the insertion can always flip depending on where you're scanning. Yeah. So in this case, when we are talking about the Achilles tendon, it attaches to the soleus muscle and it inserts to the calcaneus. When you get to another part, it might actually be reverse, yeah, where you're expecting. So, this type of pain may also be caused by retrocalcaneus bursitis, and we said bursitis is actually inflammation of the bursa. And unfortunately, I didn't have an image of the the different layers of what we see, but bursas are usually above the tendon. So bursitis, or where you'll find the collection, is usually above the tendon, which sometimes is called Achilles tendon bursitis. That is, if you find fluid above that tendon, then that is the bursa itself. Next image. So the spectrum of tears range from micro tears, and we talked about, small tears over time, to interstitial tears, which are parallel to the long axis of the Achilles. That is what is known as interstitial tears, to partial tears, and eventually to complete tears, or which are also known as ruptures. If you hear something known as Achilles tendon rupture, just know that it is a complete tear. And also it is known as a full thickness tear. Then there is partial thickness tear. It means it is a partial tears. They are just used interchangeably, those names. So tears can be acute or chronic with repeated minor traumas. At the mildest end of the spectrum, all that may be present is peritendinitis. Along just the tendon itself, there is inflammation. So location typically in young individuals with a normal Achilles tendon ruptures in the critical zone, which we said that critical zone is at the myotendinous junction, which is a region relative to watershed hypovascularity. And hypovascularity means there is less vascularity, and that is usually 2 to 6 centimeters proximal to the insertion. We said that is the widest part, yeah, which is proximal to the calcaneus. Next. So for partial thickness tears, there is often enlargement of the tendon. It would be greater than 1 centimeter, which is 10 millimeters in this case. And remember, we said the Achilles usually is less than or equal to 6 millimeters. So the range between 6 and 10 is where we call, maybe borderline and all that. We can do a subsequent scan. But when it is over 1 centimeter, you'll be able to tell that there is actually partial thickness tear with abnormal hypoechoic. Maybe for the benefit of those who are not sonographers, we have terminologies in ultrasound that we use. Hypoechoic means it is darker relative to the surrounding or adjacent tissues. Anechoic areas means anechoic would be something like a cyst. When you see a cyst, usually that is what we call anechoic. Hypoechoic just means it can even be solid, but it is darker in relation to relative to the surrounding tissues. And we said that with abnormality of hypoechoic or anechoic areas within which corresponds to the tear and associated adjacent tendinosis. Then full thickness tears, ultrasound often shows separation of the torn end with the contour change of the tendon. Also acoustic shadowing at the margins of the tear from sound beam refraction. Now this is physics of how the beam, the ultrasound wave propagates. We have things like refraction, reflection, and all that. And in this case, you'll be able to see acoustic shadowing at the margins of the tear from sound beam refraction and adjacent hypoechoic tendinosis. So you'll be able to tell the tears, because remember we said the tendon usually, maybe we'll have it ahead, but just to mention is that the tendon usually is hyperechoic. It appears brighter. When you see those dark areas, one, it can be anisotropy, which we say it is a artifact. If it is not an artifact, when you do those maneuvers and you see that this dark area does not disappear, then it is pathological. And that is what we refer to as hypoechoic areas. So next. So as you can see, this is an asymptomatic Achilles tendon. This is a normal tendon. This is how it should appear, with a normal, good fibrillar pattern, those parallel lines you can see there. you can also see that it is hyperechoic in relation to this muscle down here. You don't see the difference here. This is darker than this. So in relation in ultrasound, this would be hyperechoic in relation to this muscle. But then the bone here is also more reflective. It is even more hyper compared to the tendon. So those names are not like specific names when you see a bright thing. It is in relation to the adjacent tissues. For example, this bone here is hyperechoic in relation to the tendon. It is more brighter than the tendon itself. So in this case, the tendon is hypoechoic in relation to the calcaneus here, which is more brighter. But then when we come to compare the tendon here with the muscle, then the tendon is hyperechoic as compared to the muscle. So let's move to the next. This is an asymptomatic tendon. That is how it should appear. Now, for full thickness tear, you can see here there is a tear, and you can see there is detachment. You can even see there is some fluid here. So there is a complete full thickness, or what we could also call full width tear of the Achilles tendon, and there is a this I was supposed to remove, but the measurements, there's an image I had with the measurements. I think I wasn't able to put there, but it was located 60 millimeters proximal to the tendon insertion. You can see the tendon here it has moved away. If you measure that measurement, then there is the measurement we are measuring is actually all the way from the insertion here to where there is full thickness, to where there is the full thickness tear. It is actually approximately 60 millimeters. That is about 6 centimeters from the insertion. This is when you'll be describing. And this would basically be for sonographers when they are doing their report, because you need to tell the doctor where that tear is in comparison from the insertion point. But in POCUS, of course, you can put your probe and you're able to see that actually there is a tear here. That is, which is, it is away from the insertion point, but we don't see even where it is attaching to. So there is a full thickness tear there, and there is a gap of 25 millimeters between the two edges of the torn tendon. Now that is from here to here. That is about 25 millimeters. So the defect is filled with.
Can I add something, Nelly? So
yeah.
Keep in mind, and this is something we need all the doctors, no matter what area of POCUS you're doing, whether you're doing obstetrics, whether you're doing gynecology, cardiac, you're not asked to come up with such a detailed diagnosis, for instance, like Nelly would be asked to do in her practice, right? Because this is basically, if you're asking me as a gynecologist or obstetric doctor, what's wrong with this baby's cerebellum, then I'd be able to tell you, but that is not a POCUS job. The POCUS job is to say this is normal or this is not normal. And if it's normal, the patient goes home in most cases. If it's not normal, then you have a referral pathway. So you may be doing something like this for a general practitioner, and you're looking at this saying, you know what, this is normal because this is what Nelly has told me that's a normal view. But when I get to this, it does not look normal. We won't expect you, and usually the GPs and people that I work with will not expect you to say what Nelly just did, this is an insertion tear, and da-da-da. You just need to know that it's not normal, and the referral pathway has to already be set up by whatever GP that you're working with. The scope of care, as Chad just said, it's very important. Don't get yourself into being a sonographer. Don't push yourself into being a radiologist. Don't push yourself into being a sonologist. Your scope of care becomes very important, and whatever specialty that you go into, find out what is the expected scope of care in that specialty. Back to you, Nelly.
Thank you. Thank you. And of course, we said for POCUS, it is able to help you to make decisions. Like, for example, if you're in the field and this is a player who has been maybe participating in a football match, and they suddenly have, this sharp pain at the back of their leg and all that, and you put your probe and you're able to see something like this, this is a patient who is not going back to play. Yeah. So this is a patient who goes for care. But then it informs the decision that the return to play criteria would be, what did I see, before they can go and get a comprehensive scan done or an MRI, depending on the extent, and decisions are made. So thank you, Joseph, for that addition. And just to mention is that when you see this dark area, which we said is hypoechoic, remember we said that we need to see the tendon as a bright, appearing structure. And you see fluid here, and you can even see the tear. There is discontinuation completely. Then this would suggest even something like hemorrhage, because blood in ultrasound, we cannot tell if this is blood, if this is pus, if this is what. But in this case, because it is an acute thing, then this probably would be a hemorrhage, and it has even internal echoes. The ones like the cysts, we usually just see clear fluid like here. It would be dark like this, but you can see this one has internal echoes. So let's move forward. And you can see that there's symptomatic tendon here. Yeah, you can see that part is intact and with normal fibrillar pattern, the echo pattern that we expect to see. This is like the normal tendon, but the defect here is no longer the same. So next image, next slide. So now, like why I brought this here, this is calcification in the tendon. If you see something like this is most likely not an acute process. It is not, it is actually not, sports related at this point. This could be other things, and you send your patient for a comprehensive scan. So you can see there that, this is a non-athlete patient. They could also come to your department, and the posterior region of the distal segment of the left leg has been painful. This is what they present with, and swollen for approximately 10 days. If you put your probe there, these are calcifications, and therefore this is not a patient that you do POCAS, or you don't even make any decisions at this point. You have to send them for a comprehensive scan. Next slide. So we have bursitis, and we said bursitis is inflammation. As we all know, anything with a tis at the end is inflammation. And inflammation in ultrasound, we check in different ways. You can see there is fluid collection there, and that means that there is some inflammatory process that is happening around there. Some of the other things that you can do clinically is when you touch that area, it would be warm. And when we put color Doppler, this is for us sonographers, but even if your machine is able to do, to give the color map, you can just put it, you'll be able to see that it is hypervascularized. This is just some of the pathologies that you might find. If you're not very sure what it is and you put your probe there, you put your color Doppler there, you can be able to see that it is hypervascularized, and therefore this is suggestive of inflammation. It is an inflammatory process. Remember, we said when you're doing the Achilles, you also need to check the retrocalcaneal bursa for any bursitis, and this is how it would look like. So this goes to the class. We are not yet done, but I just want us to, in your practice or what you've come across, what are some of the other possible pathologies that you could find in the Achilles? What is it that we check? And what could be, for the sonographers, if we have some of our participants sonographers, you can also tell me what are some of the sonographic findings that you'll be able to find. Anyone who wants to try?
So I guess the question then would be, what, if you're scanning a tendon like this, what are some of the other diagnoses? And you guys are all generalists, I assume, but what are some of the diagnosis you could make if you're looking at MSK, especially if you're looking at tendons?
Or even what we've already discussed, so that I am able to know if you've understood what we've been learning or not.
And let me see.
Anyone who wants to try?
Let me see if anybody's putting anything in the chat. Come on, guys, don't be shy. This would be your GP asking you, what else can I find with POCUS? And you can look at it as you're used to looking at tendons and feeling tendons. What's some of the things that can go wrong with a tendon besides just rupture?
I'm not sure if this is valid often, but would you be able to see tendinitis or inflammation on the tendon?
Yeah, that is actually right. So some of the things that we actually find is tendinitis, and tendinitis would be inflammation of the tendon. And we said inflammation, just like bursitis, you'd be able to see there is some fluid collection around the tendon, there is hypervascularity, and that is the sonographic findings of tendinitis. Then we also have something else that is not tendinitis, which results from, it's a degenerative condition. What would that be?
Can you repeat that, Nellie?
Yeah.
Repeat what you just said, because I missed that.
Okay. So I said what he said is right. It is tendinitis. One of the other condition is tendinitis. So I'm looking for something else that is not now tendinitis, but it is still, it results from, there is no significant inflammation. Tendinitis, of course, we have inflammation, and this condition would result from long-term overuse or microtraumas, which were not allowed to heal. What would that condition be? We have tendinitis, which is active inflammation. And then we have what else? Somebody to try?
Somebody, osteoarthritis.
Osteoarthritis. So for osteoarthritis, we would actually be looking at the cortical irregularities of the bone. Yeah. But what I'm looking for here is tendinosis. So tendinosis is different from tendinitis.
So somebody
Tendinitis is
put that down. Somebody actually, Dr. Magiette has put down tendinosis.
tendinosis.
Yeah,
Yes. So
tendinosis, yes.
yeah, that is right. So there is tendinitis. You should be able to know that tendinitis is acute inflammatory process. And when you put color Doppler, you'll be able to see hypervascularity. But for tendinosis, it is actually a degenerative condition of a tendon without significant inflammation, but it results from long-term overuse or microtrauma that was not allowed to heal. So over time. So in this case, you'll actually be able to see. Remember how anisotropy was looking like? You'll see most of it in the course of the tendon itself. You'd actually see those dark areas. There's a fibrillar pattern, then there's a dark area, fibrillar pattern, dark area, and all that. That is tendinosis. So I hope that is clear. So we move forward. So there's tenosynovitis. So tenosynovitis is actually the acute inflammation of the tendon. So next, we said most of the time we just don't want to scan the Achilles tendon only. Remember, these patients will present with, there is also referred pain. The problem could be at the plantar fascia, but then they feel the pain up. So you're supposed to actually, when you're doing the Achilles tendon, you need to move your probe to the sole and check the plantar fascia. So what is the plantar fascia? It is what supports the medial arc of the foot, what usually forms that arc, and it is the one that supports it so that it doesn't drop, like flat foot. So the plantar fascia is actually what gives that arc. It supports the medial arc of the foot. And plantar fasciitis is common in runners and overweight individuals, and you'll actually come across this so much. So let's move forward. So as you can see there, we have the plantar fascia. The plantar fascia here, you can see, is at the sole down there. And we have, of course, I wouldn't expect you to do a comprehensive scan of the plantar fascia because for us sonographers, we usually scan the entire thing. We scan it in compartments. We have the lateral plantar fascia, which is this. We have the plantar fascia itself, which is the medial one there. Then we even have, extending all the way into each foot. It inserts into each toe, rather. So you can see that the whole of this is the plantar fascia. But most of the time, when you're doing the Achilles, you just check around the insertion of the heel bone here and up to around this area. That is just for your own, knowledge, so that you're able to just check quickly. You can see the probe here where it is placed. For a comprehensive scan of the plantar fascia, that one you leave it to the sonographers. It is a very comprehensive scan because they have to follow all through all the compartments. So the location, you can see here, the image is showing us the location of the structures and the position of the probe. You can see the whole of this is the plantar fascia. And this is what supports the medial foot here. Then we have the panoramic view here of the central plantar fascia with the important structures highlighted. And you can see there we have the fascia itself. And we also have this is the flexor digitorum brevis. That is, these are technical for sonographers. They'll be able to identify that. Then we have the calcaneus there, as you can see. So we move on to the next slide. So the plantar fascia aspect, the structures that usually are assessed is the plantar fascia skin and the fat pad. That one you will see it in the next image. We check the plantar fascia itself. And now the plantar fascia intrinsic muscles, these are so many, there are about 10 of them. Now this one is not for POCUS. This one, we leave it to the sonographers to be able to assess. But what we want to check for us in terms of POCUS, we want to check the plantar skin in case of any foreign body, and you want to see how deep or even the direction how it has gone, and you want to do an intervention, you can put your probe there, especially for, the foreign bodies, if you want to have it removed. So you can actually do a quick POCUS there and see that how you're going to remove it, or if it needs, and even the depth, how far it has gone. So let's go to the next image. And as you can see here, we have the plantar skin. This is the sole. Remember, another thing that you need to do is that the sole is thicker. And therefore, it means, remember, in ultrasound physics, the frequency, the higher the frequency, the lower the penetration. So in this case, when you're doing the sole, the plantar down there, you need to actually reduce your frequency to a lower, probably up to 8, up to 7, because what happens is that when the frequency is lower, then the penetration is deeper. You're able to see the deeper structures. And like the Achilles, you can see this is very thick compared to the Achilles, which you were checking with a higher frequency of about 10 to 18. So you have to lower your frequency when you get to the plantar fascia to be able to see these structures properly. So as you can see here, number one here is the plantar fascia itself. You see it's much more deeper to the fat pad itself, to the plantar skin, the fat pad. And in the measurements usually is 2 centimeters for the skin, and we have the plantar fascia there. So let's move forward. So the plantar fascia, this appears as a distinct thick hyperechoic fibrillar band, and it actually appears like the tendon. Let's go back to the image that we had. You can see it actually looks like a tendon. The plantar fascia looks like a tendon. It has that fibrillar pattern. It is hyperechoic and all that. So let's go to the next slide. So this appears as a distinct thick hyperechoic fibrillar band, somewhat like a tendon running parallel to the skin of the sole. It is approximately 3 to 4. Sorry, I had said 2 centimeters. Yeah, that is 2 millimeters. Sorry. It is approximately 3 to 4 millimeters thick. And we said that we measure at the thickest portion immediately after its origin, and 1 to 2 millimeters at its mid portion. And it has a medial band, it has a central band, and a lateral band, as we saw in the other image. But most of the time, we just want to, have a quick overview of it. Next slide. So how do we position? Just like the Achilles tendon, you don't just do anything haphazardly. You have to make sure that you actually position the patient properly. Like you'll see when we'll be doing the shoulder, we have the different positions. When you want to check the subscapularis, the position is different. When you want to check the supraspinators, you know, when you want to check the infraspinators, at some point you have to put the hand behind your inside the left, the contralateral pocket. And those those positions actually matter because you're able to see your structures better. So the patient positioning is very important. And as you can see here, when we are checking the plantar fascia, unlike when we were doing the Achilles, we didn't have the patient on their toes. But you can see here the patient is on their toes so that it stretches out the plantar fascia. It brings it more superficial so that you can be able to assess it. And this is a longitudinal, as we said, that's a longitudinal view. So you place the transducer over the plantar aspect of the hind foot to examine the calcaneal insertion of the plantar fascia. Long axis image is obtained just medial to the midline. Are used. Measure the fascia at the point where it leaves the calcaneal tuberosity. The gain may be increased to avoid beam absorption by the thick plantar sole. So remember, when we are scanning, we also have the different maneuvers, the knobology. We usually adjust the gain, we adjust the depth, we adjust the focus, we also adjust the frequency and all that. So those are the things that you will learn during your practical session, because that is what is known as image optimization. You need to make sure that you see your image fairly well. And you can see there, the plantar fascia there, this is the sole. You can see where it attaches to the calcaneus, and that is the plantar fascia, more similar to a tendon. And you'll be able to see that when you'll be doing your practice. And just below it here, we can see the flexor digitorum brevis muscle attaching just below the plantar fascia itself. So this is a long axis image. Long axis, we say it is a sagittal image, and this is how you place your probe along the foot of the sole.
So
And the
Nelly,
short axis, yeah?
can I ask a question then?
Sure.
So on the calcaneus here, right, we see the calcaneus bone here. Is this fluid here, or is this just degeneration from the sound? Or is this actually fluid here?
Yeah, so this could possibly be anisotropy. That is what we said. This could be anisotropy. It could be an artifact. But then how do you confirm that it is not fluid and it is an artifact? We said that we change the angulation. You rock your probe from side to side, small maneuvers. If it disappears, then it was an artifact. If it persists, it's still there even with the change of angulation of your probe, then it means it could be pathological.
Cool. Thank you.
Yeah. So let's move to the next. So that was the long axis. And we said in ultrasound, we don't do one plane. You have to do both planes, which is the long axis and the short axis, also known as the sagittal and the transverse or axial. All that refers to one thing. So you can see here, this is a probe position in this case. And this is obtained in the region of the midfoot. It demonstrates the plantar fascia where the arrows are. You can see there as a sharply defined flattened anisotropic band. Yeah. Remember what we are saying is anisotropic band is it now appears darker. Actually, so, as I said when I started, the artifacts can be counterproductive and they can be productive. In this case, this anisotropy of this band is able to help us identify which one is the band itself. So you can see there that this is anisotropic band, and it is between, when we said we measure it is at the mid portion, it should be between 1 to 2 millimeters. It is located superficial to the flexor digitorum brevis muscle and the quadratus plantar and the flexor hallucis longus tendon. And remember this flexor hallucis tendon, where is it going to attach? It is to the big toe. Anything that just says hallucis refers to the big toe, just the same way in the hand we have the pollicis. Pollicis goes to the thumb. So anytime that you see anything called the hallucis there, then it refers to the big toe. It just depends on where it is going to to attach? Is it to the base? Is it to the base of maybe the first metatarsal? Yeah. So anyway, what we are saying is that you need to identify these structures. When you put your probe that way, this would be the arrangement. The most superficial here would be the plantar skin, and this is where we find most of the foreign bodies. Maybe somebody has been pressed by something, but then does it go all the way deep? And how do you identify foreign bodies? If it is a bright thing, it will cast a shadow just like a bone. The way we saw the calcaneus, you're only able to see the contour of the bone and then darkness below it. So that would be foreign body. And we've said that you'll be able to see all these structures. So the structure that is, in that layer, and it is actually that anisotropy, what we were saying here, is what is able to help us differentiate the plantar fascia itself from the plantar skin up there. And you can see this is the muscle in short axis, yeah? And just below it again, we have the quadratus plantar, and we have the flexor hallucis longus, which is also another tendon. So let's move to the next. So normal features, what usually do we expect to see? We've talked about echogenicity, and echogenicity is what we talked about: hyperechoic, hypoechoic, anechoic, all those things. That is what refers to echogenicity. So when you're checking the tendon, you need to tell us the echogenicity, or not even tell us, you need to see that the tendon is hyperechoic. Then you need to see the fibrillar pattern, those straight lines that we talked about. All tendons have fibrillar pattern. In fact, when you're scanning, when you put your probe anywhere where you think there is a tendon, you'll always see the same pattern, and that is why I'm just combining them together. So there should be no hypoechoic defects, which we said when you see those hypoechoic defects, they could be either artifacts or they could be pathological, and they could be micro tears, they could be full partial, they could be full thickness tears, they could be partial tears, and all that depending on the appearance. And of course, we said the plantar fascia, this is for the Achilles, but for the plantar fascia, we said that it has different thicknesses. From where it is inserting, it is 3 to 4. Then as it progresses to the medial aspect, we get 1 to 2. I need to correct that. Then let's move forward. So we said scanning the plantar fascia technique. You position the patient, of course, we said in supine or prone. The angle dorsiflexed. The transducer, we said we still use a linear high frequency probe. We are still using a frequency, a linear probe, but then the frequency of the plantar fascia should be much lower than the one that you're using for the Achilles tendon. Then, of course, the landmark is the origin at the medial calcaneus tuberosity. So let's move to the next. So we said the normal thickness for the plantar fascia, we said it should be less than or equals to 4 millimeters at origin, and then as it progresses, we've said it's 1 to 2. It should be homogeneous. Homogeneous just means it should appear the same all through. Next. So common pathologies for the plantar fascia, we talked about plantar fasciitis, and that is, of course, inflammation, and therefore that tendon, the plantar fascia itself would be thickened, and it would be more than 4 millimeters. It would also be hypoechoic. Remember, we said we want to see it as an hyperechoic band. And then, of course, the other pathologies, enthesopathy means that it is just pathology at the insertion points. So if you're able to see any pathology there, that is what it refers to, and it could actually point to partial tears. So next.
So we have one question, Dr. Makan. wants to know, so the hypoechoic regions that you find, if they are not artifact, we should consider that they are fluid if we can prove that they're not artifact. Like or edema, basically.
Okay, so it's not fluid per se. What we said is, if let's say the tendon, the fibrillar pattern, the parallel lines that are running parallel, and then we see dark areas, it doesn't really mean that it is fluid. It means that they could be tendinosis, they could be a tear. But when it is fluid, it would depend on what the fluid looks like. Like, for example, if it is an acute pathology, then you could actually think that it is hemorrhage at the point of the tear. But then remember, we talked about tendinosis. Tendinosis is prolonged micro tears which were not allowed to heal over time. And those are the ones that would appear in between the fibrillar patterns. Remember, if there is a tear, you will actually see where the tear is, the discontinuity of the fibrillar pattern. But in tendinosis, you actually see like there is a continuation, a break, continuation. There are multiple dark areas. So it doesn't really mean it is fluid. Those could mean that they are micro tears over time. That could actually be pointing more to tendinosis than actually a full, and eventually the tendinosis could lead to partial tears or full thickness tears. I hope I have answered you well.
Yes.
Okay. So pathology clues. This is just, as I said, all the tendons look the same. The plantar fascia there also looks like a tendon. So what would we be looking for? The clues that they could be pathology. We talked about hypoechoic areas could point to tendinopathy, but then you need to know which one. So one of the things that we said we can distinguish between tendinosis and tendinitis is, or even tenosynovitis, is active inflammation, and therefore there would be hyperemia on color Doppler. Then, of course, what are we looking for? In case of a tear, we are looking for discontinuity. Remember, those fibrillar, the pattern should be continuous, and you should be able to see it all the way from where it originates to the insertion point. It should appear the same with good fibrillar pattern. If there is discontinuity, then it could point to a tear. Next. So what is the clinical relevance for sports medicine? So Achilles tendinopathy, we've said it is common in runners and jumpers, and therefore POCUS in sports medicine is very important. Then plantar fasciitis is common as well in runners and overweight athletes, and it is still something that we can still use to be able to diagnose and see if they can be able to go back to the field at that particular moment or not. And if not, after how long? And of course, still, we can use it as a tool to be able to monitor healing over time. And then we have ultrasound also allows real-time assessment. That is what we said. Guided intervention, which is the PRP injection, like the one Joseph got. We also have dry needling. Those are for orthopedic surgeons, or any form of intervention in the clinic. They are able to use it, and that is one of the relevance why we are actually doing POCUS. Because I mean, if like the orthopedic doctor that Joseph was seeing, he was able to do the injection using the ultrasound guided. He was able to see it using ultrasound, and therefore it makes his work easy. You don't need to look for a sonographer who probably are not even available. You need to manage your patient quickly. And of course, we talked about dynamic scanning, which helps to evaluate functional deficits in real time, which even an MRI cannot be able to achieve. So that is the clinical relevance. Why are we learning this, especially in sports medicine? Because POCUS, MSK POCUS, usually points more to sports. Next. So apart from I know that most of us know that MSK would, point to muscles, the tendons, the joints. You want to see effusions and all that. But actually, one of the other MSK points is the anterior abdominal wall. That is something that, we haven't been able, some of the practices, especially here in Kenya, sometimes people take, you're sent for, you want to check for a hernia, you want to check if it is reducible or non-reducible. Mostly it would be an abdominal scan that is sent, yet actually it should be a musculoskeletal. So anterior abdominal wall is one of the things that has been forgotten, and ultrasound is very useful for evaluation of the anterior abdominal wall. For example, we want to check, hernias, muscle tear, soft tissue lesions, which are usually known as lumps and bumps, like the lipomas and all those things. Those are what is known as lumps and bumps. And another big area is, you can still use POCUS in your setup, let's say in your examination room. For example, a patient is telling you I have a big swelling. Like for me, myself, I have a lipoma somewhere around here. And all I did was just to put a probe, and I was like, that is a lipoma. It can just stay there. So you can make a decision because, yeah, one day I woke up and while I was dressing up, on the mirror, I was able to see there is, something protruding on this side, and this other side was okay. So I was like, what could that be? And some of the other things that, of course, I checked, lipoma is usually mobile. If you feel that it is actually moving around, it's a good sign.
Yes.
And when I went to the clinic, of course, I just put my probe there and I saw that that is a lipoma. And I mean, if this was just your patient in your clinic and you've put your probe there, you've seen this is a lipoma, it's really nothing much. You can actually just reassure the patient or even send the patient now for a proper scan. They don't need to be really worried, so that they actually have that confidence. So we also have ganglion cysts. Remember, when we are doing the MSK, especially like if you're checking the wrist, we have those ganglion cysts. We might find them in the wrist, and it is very important to be able to know how they look like. We also have abscesses. You can have an abscess. The patient comes in and they are swollen everywhere, and you want to check, is this an abscess? What could this be? Before you send them even to the radiology department for a comprehensive scan, of course, you'll somehow have also an idea of what to expect. Then foreign body detection, that is what we already talked about. If you need to remove, let's say, a foreign body, you really don't need to have that patient go and get, a comprehensive scan, and it is just a foreign body. You just want to see how deep it is, and you're able to remove it. Then next slide.
So just to add that the couple of things, the ganglion cysts, a lot of the orthos or other generalists will look at them and then want to aspirate them if they're causing too much pain or anything. And that is another ultrasound POCUS procedure that can be guided by ultrasound. So if we have somebody that knows how to use POCUS and know how to do ultrasound guidance, that'll be very good. And I can relate to when Nellie said lipoma, because Nellie, the same thing happened to me. I was I went to the gym, worked out, took a shower, was getting dressed, and I kind of looked at my side for some reason, and there's this lump, and I'm like, oh my God, because we're all used to imaging, and lumps are never good. So luckily I had an ultrasound machine at home. I ran home, scanned it really quickly, it moved around, no Doppler signal, I was good. So I can definitely tell you're going to have patients that come in that said, oh, this lump just popped up. You need to know the difference between a lipoma and something that you should get a higher referral to. So thanks for that, Nellie.
Yeah, you're welcome. And just to add also on that, for postoperative patients, if a patient had like a surgery and they come back, they have like swelling around the incision site, you can still put your probe there and you just see there's some collection that would point to probably an abscess that is forming. Yeah. And of course, you'll have done also your clinicals. You might find that they have fevers and all that. And when you just put your probe there, you're able to find that there's some fluid collection around the scar line or the incision site. And that would tell you that this is a patient that really you need to manage, probably give them some medication and all that. They don't really need, to go to the department and all that. This is something that will help you to make your decision very fast. So what will you learn in a full POCUS training? We've said we learn, POCUS of all major joints, as we said, the shoulder, the elbow, the wrist, the hip, the knee, the ankle, and all that. We'll also do pathology recognition. We'll be able to see which ones are, you know, how you check the tendons. Remember, there are also ligaments, how nerves appear. And in most cases, in ultrasound, as you will see, the blood vessels usually move together with the nerve, but the nerves usually have an appearance that is known as honeycomb appearance. As it moves along, you can be able to tell that this is a nerve. And of course, we'll also be able to see how muscles look like. Then intervention guidance technique, that is what you'll be able to learn. And then, of course, the hands-on practice. There is no ultrasound that is learned on theory. You have to scan, you have to practice. Yeah. So next slide.
So one more thing to add to that. One of the things when, like Chad will probably tell you, when we graduated, they didn't really teach us ultrasound. I mean, we saw it, but the sonographers and the radiologists, they were the ones that were the gods of ultrasound. We weren't allowed to touch that thing unless we were just like rotating through the department. One of the things I found that really helped me, if I was on call one night and I had to do, for instance, something that was non-gynecological, like a gallbladder or a right low quadrant, I often would scan myself before I scanned the patient to know what normal looked like, to remind myself that this patient is complaining that there's a lump here, but let me go in the background. I'll scan myself real quick, get that picture, so I know that when now I'm looking at the patient, this does not look normal. And then the second thing you guys need to be really cognizant of, those of you who are going to be doing gynecological and obstetrical scan, hernias are really, really prevalent in pregnant women, especially if they've been in any kind of trauma, car accident. We've seen seatbelt related trauma cause an abdominal hernia in pregnancy. So you will get patients that come in and say it suddenly hurts here. You cannot just dispel it to, oh, it's just a baby kicking, because it could be a hernia that she's experiencing that you may be able to diagnose. So my thing is treat the transducer like you would treat your hand. If you go and examine a patient and you're pressing on let's say you're pressing on their stomach and you're checking for rebound tenderness, you should generally be able to use your transducer to say, hey, is this an appendolith that I'm dealing with? Is this appendicitis? So let it become an extension of your hand.
Yeah, actually, to add on that is that POCUS, usually they say, is an extension of the physical examination. It is an extension. So something else to note is that for anterior abdominal wall defects, we still use the linear probe. We don't use the curvilinear, because remember, most of these things are more superficial and we want to use a high frequency probe. So moving forward, I want to take back to Joseph. And if there are any questions, you can ask. And from here, I think I'm done with my presentation. So Joseph can take us forward.
Okay. Thank you so much, Nelly. And I think we all have learned, I know I have learned a heck of a lot from this lecture, because I'm not MSK qualified in any way, shape, or form. If it doesn't have ovaries, I'm not looking at it. So, I think that we should turn it over to see if there's any questions. Any comments? It doesn't have to be questions. Did you think you learned anything from this? We don't expect you to go out and start practicing this right away, because there is some hands-on that is necessary to actually learn MSK. I find MSK really difficult unless it's something straightforward like a tendon or an abscess. I find it extremely difficult, because if I'm looking at a baby or I'm looking at a fetus, or if I'm even I find MSK harder than doing a fetal echocardiogram, and that's saying a lot. So it's just about who is doing it and how experienced you are, and are you willing to learn doing it. And Chad has said this, Dr. Chad has said this, that it is going to take some learning even after this program. I mean, we'll have classes available after this program that you guys can kind of learn that maybe are not a part of this program, but it doesn't stop with this program at all. Nelly can tell you she's been in this for 10 years, and I'm positive that Nelly sometimes goes to work and picks up things that she didn't know yesterday. So you will always be learning. Chad, anything to add from you?
Yeah, sure. Thanks, sure. Yeah, thanks again, Mr. Nelly. It's really cool I know dime a dozen these days to find MSK MSK specialists. And I think also for the doctors, like for us as clinicians, there's you see the value in a sonographer, because if you think back to like when we were working in primary, or let's say secondary and tertiary hospitals, those sonographers that were in their rooms, they used to do the formal scans for when we were operating in, when we were moving through surgery and ortho and obs and gynae and all of that. And I don't know if you guys ever spent any time there, but I often used to go down to the sort of radiology department and just go sit with the sonographer specifically. And there usually was like one or two of them doing the whole hospital's work.
Yes.
Um, and it's quite intense, but I mean, it's so incredible for me to the fact that, that they knew, and they did more scans and were better at scanning than every single consultant I ever knew ever.
Mm.
Other than, yeah, and there maybe a physician who was very good at maybe an echo or something. But 9 out of 10 times, the sonographers were the ones who were absolutely incredible at it. And I think it's just such an amazing opportunity, to be able to get trained by, the team, the clinical team. So I think that's just number one. So thank you, Nelly, for that. And then I think why I liked it so much, and why I'm also just saying thank you again to you guys for suggesting the MSK. I think Joe and I did speak about MSK up front when we were looking at what are the common things that's going to allow you to most likely get scans and have patients come through and generate revenue. And Joe and I had some back and forth about it, and I was saying to him also, you guys know how many times we used to do things like aspirations and taps and things, and we always did it blind, right? For the most part, we would do taps, we would percuss, and we would just find the dull space, and we would just go in there. And it was really, look, I mean, that was in public sector for the most part, but if you think about the private sector, the patients also gauge the level of care, right? The perception of the level of care based on how the doctor is doing things. So for any in the private sector, the primary care level, if you think about it from a customer point of view and a value proposition point of view, I remember, so we had a patient now, not too long ago, in the week, 2 weeks ago, that came to one of our physical branches, and it was a young couple that were just recently found out they were pregnant, and I think I mentioned in one of the sessions before, and they ended up doing a beta HCG at Mediclinic, and that was the completely wrong care pathway. But anyway, he ended up getting a bedside dating scan at one of our branches, and the doctor actually said, "Yo, this guy was so shocked. He was like, is this thing gonna use? Are we using that?" Like, they couldn't understand it. Like, it obviously worked out an ultrasound, and it was just so cool. And again, that's the experience that patient has. They feel their doctor is at the top of their game, right? They know they've evolved, they're advanced. The same thing would go for doing something maybe that traditionally a GP would do blind, like intra-articular injection or even an aspiration on a knee. But to use ultrasound guided, doing it ultrasound guided, it just brings that value, that value to the customer. So I think that's a big thing to think about when you're engaging with the GPs you're going to be onboarding. Yeah, and then here's another comment here. We should touch on the ligaments for ankle sprains with query fracture. There's always more to learn. 100%. No, and I think, Mika, I think what's going to happen is like obviously Joe and I, we plan these things out quite in detail. And I think what we'll do is, sorry, they're just busy at my house and some, not construction, but they're just busy building some stuff here. I think because we've now added MSK, we're going to do the same sort of course approach like Joe had on the LMS, right, Joe?
Yes.
We will add in a little bit more detail, a little bit more, some little courses and quizzes, because it's fun. The only difference really for this, and I think a traditional kind of clinical training thing, is the fact that it's in the context of equipping the doctors to it's beyond just getting the clinical exposure. It's about how do I position this in a market and go build an income from it. And this is I mean, this is quite a unique thing, right, Joe? Even across the other areas we look at, adding in that angle and that outcome does dictate in a way how and what you look at, how you do it and what we train, especially the lower hanging fruit, because we must always think about what's gonna get you scanning. Right?
Yes.
You can do the most fancy stuff, crazy focus stuff, but the reality is at a primary care level, which is where we're going to be operating 80% of the time. We need to align with that, and nothing stops us from doing the sports focused things. You know, you can obviously go to a soccer club and be on standby on the side, like Nelly said. It's that whole thing of, if you do get hurt and there's maybe a potential rupture, you know you can scan it on the side of the pitch. Player can either continue or not, but that impacts the care pathway like immediately.
Mhm.
The sooner you pick up that there might be a ligament tear or something, the sooner that guy can get off the field, and the quicker he can get to recovery. So that's how you kind of, your value proposition there changes again, because now for a team, a coach, you're telling him that you're reducing morbidity, because the sooner you get the guy fixed up and appropriately referred, the sooner he can get back on the field and play. Because to that coach, that player is income, right? So that player needs to be on the field. He needs to be at his best. So it's just interesting, and I'm excited to see how you guys kind of use the MSK specific thing as a revenue generator. I think it's amazing. But yeah, we'll focus on getting those lists to you guys and the resource pack. We added an admin. Well, yeah, we added some more stuff to the LMS, which we're finally getting right now. Thank God. Annika has been great in getting us sorted there. And then, yeah, that will all be available. And the MSK course will be the same. And then we'll also touch on it on the in-person when you guys do your scanning sessions. I think, Joe, we might just touch on it a little bit.
Yeah. And just to add, Chad, I think that one of the things that you said really hit me is we need to think of what is the revenue generating needs, as well as the niches that are not being fit yet, because POCUS is now able to fit in some niches that previously couldn't be touched. I cannot keep sending normal first trimester ultrasounds to sonographers that are already overbooked, already overworked, and they don't want to do it. I mean, they will do it because it's their job, but they don't want to do it. No sonographer wants to put a probe down and identify a common DVT that you could have identified in your general practice office just by doing a simple linear compression on the area that the patient is pointing at to tell you that this area is red, it's swollen, and it wasn't there last week, right? So it's a matter of figuring out, and Chad and I had talked about like making a scope of practice list. We did it for our midwives in Kenya. We made a scope of practice list. These are the things you can diagnose. So I think we'll be working on that too. An area of pride for me, and I'm sharing my screen with you guys, this was one of our hands-on training in Nairobi with, we were training doctors here. And here's Nelly and I. Actually, I'm not doing anything. I'm just holding it. Nelly's doing all the work. So it just gives you an idea of what's going on in the rest of the world. And this is something that I'm really, really proud that you guys are involved in, because I see that when I come back to check on you guys next year, it will have revolutionized the way that imaging and POCUS is done in South Africa, because we're not there yet. You guys are actually the bullet that's leaving the gun right now. So let's see what you can do. I'm anxious to see with us supporting you what you're capable of. Back to you, Chad.
So sorry, let me
Yeah,
interrupt a little bit, and let me also take you a little behind. I want to also add something on the ligaments, what Mikhail asked about the sprains. That is, mostly we'll be checking for subluxation. And in this case, usually for the ligaments, remember they join another bone to another bone. And that means what we usually do as sonographers, we check what is known as joint gapping. If it is, you compare with the contralateral leg. For example, when you do the maneuvers, remember we talked about the dynamic maneuvers, and each joint has its own different maneuvers. Yeah. So there is what is known as front drawer, where you pull the leg when you're doing different types of the maneuvers that we do. So usually the gapping, you have to compare with the other one. And if the difference is more than 2 millimeters, then it means that that ligament likely has laxity, and that could mean there's subluxation. So that is how we assess. It is a dynamic scan. You don't just do it as a static scan. You have to put stress, and you compare with the one that has not been applied stress on. So
Thank you, Nelly. Now you guys see why it's so important to be friends with your sonographers, because this is where you're going to learn. Definitely where you're going to learn.
Yeah. So cool, guys. Yeah. So I think we'll wrap it up there. We will have because as you guys know, it's a journey, right? So it's 18, 24 months. We're gonna be building together. Our goal really is for you guys to get to 200,000 Rand a month revenue between scanning, virtual care, locums, etc. That's truly our goal. And I believe we'll get there over the next 18 to 24 months for those who stick the full course and really kind of pick it out and get invested. And I'm excited for that, man. And yeah, there's a lot of buzz. Just so you guys know, like people are starting to buzz about this a little bit in the industry. I had a meeting on Friday just before we go with a head economist that's been working on the NHI for the last 13 years. She was a lead public health economist, and she was working directly with Dr. Musculoskeletal and whatever on creating the benefit packages. And she's obviously gotten a good idea of what we're doing. And it was just so refreshing to get such good feedback from someone who's been pretty much their whole life now trying their best to create these public benefit things. And how it's gonna look, what is the care package gonna look like, or what's NHI gonna look like. It's hectic. But she also reiterated, she said, the empowered clinician that's coming up with innovative models and is working towards universal healthcare is ultimately what's going to fix the country. And she just said to me how far away and how challenging it is at an NHI policy level to create economic models that work for everyone. It's almost impossible. But at a micro scale, hundreds, if not thousands of doctors doing it in their own worlds is where you're going to actually shift the needle. So, so I just wanted to encourage you guys to the heights of the of the department. Things are, you guys are being spoken about and what you guys are doing and what we are doing. Very exciting times. Everyone will just keep their heads down and push through the uncomfortable phase, which is now. And I'm sure within the next 6 months, everyone's going to be doing pretty well.
Absolutely.
So,
And I can also tell you guys that people are speaking about you internationally, because I had a meeting with Kenya Healthcare Federation today, and they're trying to figure out how they can reproduce what Chad and the team are doing, because there are like groups of 300 and 400 doctors. And Nelly, you know this, there are groups of doctors that do rural care. We have the RUFA Association in Kenya, which is a rural urban physician association. These are doctors that are in the backwoods doing house calls and things like that, and they're an association. And so Kenya now is trying to wrap its head around, okay, Chad is doing this in South Africa with this amount of doctors. How can we reproduce this on a wide scale? And the same thing with Nigeria also. I had a call with them day before yesterday. So this is something that everybody now has their eye on you guys. No pressure at all. But it's going to be something where everybody's now looking to South Africa to lead this charge. It's a good thing. It's a good thing.
Yeah, it's a good thing. I'm proud of all of you. There's a couple of more things to sort out admin-wise before you guys go into the world, and the in-person sessions must still happen. We're doing the telemedicine session tomorrow. And then we're just liaising with Joe and the team just to get the logistics right for the in-person. And then you guys will be engaging with Zero and SME.tax, which is the accounting firm we brought on board to support you guys. Quite a few exciting things happening, and we're almost ready for you guys to take on the market. So have a good evening, and thank you again. And yeah, I really appreciate you guys' time. Thanks, Joe and Nelly. Appreciate it very much. Have a good
Thank you.
evening.
Thank you, ladies and gents. Thank you, guys.
Yeah, thank you, everyone.
Thank you for the
Cheers, guys.
presenters. Thank you, Brad. Thank you, Joseph.
Cool, guys. Thanks, brother.
Cool, man.
Chat
Cool.
soon. Thanks, Joe. Bye. I'm gonna go now. I see you too much, bro. Bye.